How's it going, guys? We have a medium difficulty question for hematology. 39-year-old woman, 1 week history of epistaxis, no past medical history. Hemoglobin slightly low at 11, should be 12 to 17.5 menstruating women, 13 to 17.5 non-menstruating women and men. Leukocytes normal 5,000, should be 4 to 11,000. Platelets low 40, should be 150 to 450,000. Prothrombin time normal 12 seconds, should be 10 to 15 seconds. PTT normal 27 seconds, should be 25 to 40 seconds. Bleeding time elevated 9 minutes, should be 2 to 7 minutes. So we have an elevated bleeding time, low platelet count, slightly low hemoglobin, which could be iron deficiency anemia secondary to the epistaxis, as well as her menses because she's menstruating age. We have this smear I'll talk about as we move through. What's the next best step of management? Choice A, cryoprecipitate is wrong. This is usually a wrong answer in USMLE. It can be the correct answer if a patient has disseminated intravascular coagulation, where the question goes out of their way to explicate that fibrinogen levels are extraordinarily low. Wrong fucking answer. Choice BFFP is wrong. It'll be the answer in two situations in USMLE. The first, the higher yield one, is rapid reversal of warfarin for the vitamin K deficiency. Patient has bleeding on warfarin, needs to go into surgery because it's supplying lots of clotting factors. The slow reversal of warfarin, of course, is going to be just supplying vitamin K. It takes the liver days to synthesize, activate the clotting factors. The second indication for FFP is simply DIC. So when we treat DIC, if they list both, choose FFP over cryoprecipitate. Only choose cryoprecipitate if they go out of their way, as I already said, to explicate that fibrinogen levels are extraordinarily low. FFP, wrong fucking answer. Choice C, desmopressin therapy, vasopressin analogs, wrong. Could be used for von Willebrand disease to stimulate factor VIII, because one of the roles of von Willebrand factor, in addition to bridging glycoprotein 1b on the platelet to vascular endothelium / underlying collagen for platelet adhesion, the other role of von Willebrand factor is to stabilize factor VIII in plasma. So desmopressin, which will stimulate release of factor VIII, can be facilitating in von Willebrand disease. But the other indication for desmopressin is going, when we're talking about hematology, of course, is going to be for hemophilia A, okay, because of the stimulation of factor VIII production and release from endothelium and platelets. So we prefer giving desmopressin for hemophilia A before giving factor VIII, because when you start giving the clotting factor directly, the immune system can develop antibodies against it, resistance. Those antibodies are called factor VIII inhibitor. Same thing goes for hemophilia B and factor IX. So if you start resupplying the clotting factor and the PTT doesn't go down, the next best step is going to be check for factor VIII inhibitor, check for factor IX inhibitor. Desmopressin you can use for hemophilia A, but you can't use it for hemophilia B. Wrong fucking answer. Choice D, oral iron, is wrong. Now, some of you are going to get emotional, but I'll make this very easy as far as why this is wrong. You could say, well, the smear looks like we have pale RBCs here. I agree with you. Okay? It looks like there's central pallor here. Even though I Googled ITP smear, which is what we have. This is apparently a normal smear, just the platelets aren't there, okay? So argue with Google, all right? But the main point is that even if you want to say that she probably has mild IDA due to the nose bleeding or her menses where the RBCs look pale, even if that's the case, that wouldn't explain your high bleeding time and your low platelets. You wouldn't have that with iron deficiency anemia. So clearly there's something more going on here, right? So this is ITP. And now what you got to know for USMLE, ITP, which of course is going to be usually viral infection. They'll only mention the viral infection at half the time. Viral infections are often asymptomatic, but it's a molecular mimicry type 2 hypersensitivity response where the immune system develops antibodies against glycoproteins 2b and 3a on platelets for platelet aggregation. Okay, and it causes low platelets and high bleeding time. Now, the two main presentations, 4 out of 5 times will be a school-age kid who has nosebleeds, petechia, easy bruising. 1 out of 5 times, it'll be a woman 30s to 40s with random bruising, where it can be confused for domestic abuse. So if they give you a woman who's 40, she's got random bruising, and her labs are normal, domestic abuse. If she has high bleeding time, low platelets, it's going to be ITP. It's important for family medicine in particular. So I said 4 out of 5, the school-age kid, 1 out of 5, the woman 30s to 40s. And then 50% of the time overall, it's going to be viral infection versus 50% of the time they won't mention the viral infection. So our treatment for ITP is going to be prednisone first, steroids first, then IVIG, then splenectomy. It's a long seminar. Okay, there's nuances in pediatric cases that are very mild. You can theoretically observe, but that's not going to show up on USMLE. They still want steroids. In the setting of your platelet count literally being near zero, sometimes you could contend that IVIG is given first. Still not what USMLE wants. They want steroids first. So steroids, then IVIG, and then splenectomy. Now, if you perform a splenectomy and then the platelet count goes back up, and then 6 months later the platelet count goes back down, the answer NBME wants is accessory spleen. Sounds weird. You got to know that there's a small percentage of people who have a second spleen the size of a pea. And if you take out the main spleen, the accessory spleen will grow and the ITP can come back essentially. Prednisone? Correct answer.